Welcome and thank you for standing by. At this time, all participants are on a listen-only mode until the question-and-answer session has begun. At that time, if you would like to ask a question, press star then 1 on your touch-tone phone. Today's conference is being recorded. If you have any objections, you may disconnect at this time. Now let's turn the meeting over to Ms. Michelle Carney. Thank you, and you may begin.
Hi, thank you. This is a pre-application webinar for folks who are interested in applying for the Cooperative Agreements for State-Sponsored Youth Suicide Prevention and Early Intervention. This is RFA number SM-14-008 that's offered by SAMHSA, the Substance Abuse and Mental Health Services Administration. What we're going to do today is we're going to go over some of the basics of this program, some things to keep in mind as an applicant. And for those of you who may be familiar with this program, we're going to go over some of the ways in which this program has changed, some of the improvements that we've made, some of the augmentations that have been made to the program. So we're going to go through some of those things in detail. And some of you have contacted us with questions about this RFA, and so we've tried to integrate some of those questions into the presentation as well so that everyone can benefit from the questions that you've asked. So we're going to start with a little history, a little overview of the program first, and then as we step through the different sections of the RFA, we'll wrap up with some resources, and then we'll have some Q&A at the end when you'll be able to ask some questions. So as you think of things while we're talking, just hold on to your questions. You may find that it gets answered during the course of the webinar, and then if it's not, then we'll have some time at the end. So at this time, I want to have our branch chief, Dr. Richard McKeon, say a few words to you just about the overall history and intention of this program before we dive into the RFA.
Okay, thank you, Michelle. So first off, let me thank all of you for your interest in applying for the Garrett Lee Smith State and Tribal Youth Suicide Prevention grants. We are glad for your interest and want to encourage you to apply. Let me just give you a brief overview of the program if you're not familiar with it. The program was first launched and grants were first given in 2005 after the passage of the Garrett Lee Smith Memorial Act. The Garrett Lee Smith Memorial Act was passed by the United States Senate and the House after the tragic death of Garrett Lee Smith, who was the son of United States Senator Gordon Smith from Oregon. And Senator Smith became a powerful advocate for suicide prevention, and his colleagues in the Senate supported the work, and it was passed by both the House and the Senate and signed into law by President Bush, and then has continued since 2005. It's really the first national effort to provide resources across the country to states, tribes, and then to college campuses as well in the separate grant program to reduce youth suicide in America. And so it has been a very important program operating over these last 9 years. Grants have now gone to 49 of the 50 states and to dozens of American Indian tribes and tribal organizations, as well as Alaska villages. So it has played a very important role in our youth suicide prevention efforts. One of the things that you'll note in this application is that there are several things that are different. In particular, the amount of money in the grants is larger, and the amount of time for the duration for the grants is longer. So while in 2005 the grants were for $400,000 for 3 years, or a total of $1.2 million over the life of the grants, these grants, being over $700,000 for 5 years, are over $3.5 million, so almost 3 times as large. So why have we done that? Why have we made them bigger, longer, and as you look at the criteria, really more ambitious? And the reason for that is that we are very encouraged by the work that's been done through the Garrett Lee Smith Memorial Act to date. In fact, we have some evidence which we have presented at recently at the American Association of Suicidology and are preparing for publication, indicating that counties implementing the Garrett Lee Smith activities have some reduction in mortality, which is wonderful. But what we've not been able to do is to bend the curve nationally to bring down suicide among those in the age 10 to 24 age range that are established by the Garrett Lee Smith Memorial Act as the focus of our efforts. So we are really looking to try to bring those numbers and rates of youth suicides and young adult suicides down. And so for that reason, we have tried to give more resources, to give a longer period of time, and to ask for more from grantees in order that we can have a larger impact on our national suicide rates. So with that, I will turn it back over to Michelle.
All right. So thank you, Dr. McKeon, for that overview and the sort of the philosophy of the RFA that we're going to be delving into. So for those of you who aren't familiar with SAMHSA, this gives you a sense of our mission and who we are. The point of SAMHSA and our intention is to reduce the impact of substance abuse and mental illness on America's communities. And we see ourselves as in a number of roles, including being the voice and leadership for behavioral health, funding service capacity development, information and communications, doing some regulation and standard setting, and then improving practice. And so we do that through a number of strategic initiatives. There are 8 of them, and you can see right there on the top is the prevention of substance abuse and mental illness. This particular award, as Dr. McKeon mentioned, it is a cooperative agreement. It is much larger. We are anticipating 24 awards up to $736,000 per year for 5 years. The 10 to 24-year age range remains the same, but we are emphasizing that grantees must address the entire age range, and the applications are due May 19th. So eligibility. So first of all, state agencies that apply must be identified as the lead for suicide prevention in their state. If you're a federally recognized tribe or tribal organization, you're eligible. If you're a U.S. territory, such as Guam, Samoa, Micronesia, CNMI, you are eligible. Previous grantees are eligible. If you've received this grant in the past, that doesn't disqualify you. However, if you are currently funded, if you're in years 1 or 2 of your grant, you are considered a currently funded Garrett Lee Smith grantee, and you are not eligible for this RFA. So one of the questions we've gotten is, well, if a state and a tribe are in the same state and they apply, is that okay? The answer is yes. If you're not currently funded, obviously, as I said, if you're currently funded, you're not eligible. If you're not currently funded, each state can submit one application on behalf of the statewide effort, and each of the 565 tribes and villages is sovereign, and the state application does not supersede that, so it's considered separate. And the states and tribes do compete for the 24 funded applicant slots. So as Dr. McKeon touched on, this program started in fiscal year 2005, and you can see the progress of awards over time and how much money has been allotted to this program, including last year's, the 7 awards that we made last year. So there's been some shifts around this program, and we're excited that this new redesign is really going to be impactful and really start to, as he said, bend the curve for suicide prevention. So since this grant started, we've funded 96 grantees over these years. We've done 49 states, including, and then Washington, D.C. on top of that. There's 45 tribes and tribal organizations that have been funded, including one Pacific jurisdiction, Guam. And Goal 4 of the National Strategy for Suicide Prevention is focused on developing and implementing community-based suicide prevention programs. So that's us. That's what this grant is all about. It must be guided by a statewide or tribal suicide prevention plan. And we also want you to be aware of the Garrett Lee Smith Campus Program, which is a 3-year program, $102,000 a year. And you can see we've got a number of campuses at various states of progress through this program right now. And this is an opportunity for you to collaborate with these different campuses and colleges in your states and areas to do truly comprehensive community-wide suicide prevention. So we want you to be aware that that program exists, and we would love to see you partner with currently funded campus grantees. So for those of you who are familiar with GLS Classic, there's some things that haven't changed. You have to allot at least 85% of your budget to direct services. 5% goes to institutions for higher learning. You must have active parental consent. We expect to see public and private coalitions and partnerships, and there is a cross-site evaluation, which we'll talk about a little bit more, and the RFA talks about this as well. So for those of you who are familiar with this program, those things remain the same. And one of the questions that we've gotten is, when does the project period actually begin? Oftentimes this program follows the federal fiscal calendar and begins in late September, but there have been occasions where it has started a little earlier. It sometimes starts in August, and that's something that you know, we're not completely sure about. Sometimes these things occur. So what we've been encouraging you to plan for is just to generally know that in the fall is when this program will start. So what's new? So we've got a little comparison here across the program in terms of history versus now. So it used to be that you could choose your focus around the 10 to 24-year-old age range, but now we expect that you cover the entire age range. Historically, the grants were between $500,000 to $440,000 for 3 years, and now they are $736,000 a year for 5. Gatekeeper training was often the cornerstone of a lot of grants, but now we expect an increase in the clinical training, continuity of care, post-discharge ER follow-up, and we want to see a demonstrable reduction in suicide. In the past, a partnership with a behavioral health system was encouraged but not required, but now that's something that you absolutely must do. And one of the common questions we get is, what do you mean by direct services? Because it's a little ambiguous, and that's intentionally ambiguous because we mean a lot of different things when we say that. It can be things like gatekeeper training, clinical training, screening, referral, and follow-up. Postvention support to survivors is also considered direct services. And you'll see in Appendix J there's a participant protection section which, you know, goes through what you need to do in order to offer those things. But one of the questions we anticipated was, well, can we use the grant to pay for direct treatment services? Well, on page 6, there's a little bit more information about what that means, page 6 of the RFA. So the answer is yes, but it depends on how you define that. We don't typically pay for traditional mental health treatment services, and we cannot supplant mental health dollars. But if it's part of a comprehensive plan, and if it's follow-up, if it's risk assessment, if it's monitoring, entry to clinical care, absolutely. If it's case management, that's fine too. So there's a couple things that are new and notable. You'll notice that this RFA has some new material in it. This is the first time that we've mentioned the connection of a serious mental illness and mood disorder with suicidality, and we've put a renewed focus on assessment and access. Those are on pages 9 to 10. And then on page 10, you'll see a very long section on the National Strategy for Suicide Prevention. You must use surveillance data, both attempts and deaths, to inform and improve your efforts. Crisis response plans are required. Post-ER discharge follow-up is required. You have to incorporate lethal means restrictions for those who are identified. Your public awareness campaigns must be safely messaged and connected to taking action. We have a new mention of having something like a youth council where you're able to get input and feedback into your program, because these are the people that you're serving in your program. We also want to see things like loss and attempt survivors' involvement and their input and feedback as well. And we're mentioning the materials from the NSSP as well, things like clinical workforce preparedness and youth in contact with the juvenile justice system. And then if there are additional sections of the national strategy, you may include those in your application as well as you see fit. So in Section F of the electronic health records, that's page 12, and then there's an Appendix K. If you are not providing clinical services, then this section does not apply to you. However, if you are, then we expect you to describe the system you're using or the plan to acquire a system, and that system has to include suicide prevention. Section G asks you for your state or tribal suicide prevention plan, and Section H includes your community readiness assessment, which is something that a lot of tribes often use in order to determine where they want to start with their prevention efforts. But we'd like to make sure that that's been conducted in the last 18 months, and it has to be on suicide prevention. And each of those sections above is worth 5 points. So one of the questions I've got is, well, what if we don't have a suicide prevention plan and or a community readiness assessment? Okay, you don't have to have both, but you do have to have one. You either have to have a state or tribal suicide prevention plan or a recent community readiness assessment. And if you don't have either one of those, then you may want to consider another grant program. There's a couple things that are coming up. You may want to look at the HHS forecast, and you can click on SAMHSA, and it will show you the grant programs that we anticipate announcing. So you may want to take a look at that and see if there might be something that's a better fit for you. For data, we are going to ask for many more indicators. So many of you who are familiar with the data we requested in the past, we track on things like screening and referrals and how many people have you trained and how many people have you reached through your public awareness campaigns. But with this new, larger RFA, we're asking for more stuff. We want to see organizations collaborating and sharing resources. We're going to track on policy changes. We want to see improved readiness for your organizations to change their systems. We want to see more organizations getting mental health data and using it. We want to see them implementing mental health practices. We want to see more communities that have established systems to share the service delivery across their agencies. We want to see more advisory group members who are consumers or family members who are suicide providers. And we want to track on the number of individuals contacted through your program outreach. And all of the above is as a result of your grant. All of these things have to be tied to the RFA, the particular grant that you have been awarded. So this gives you an overview of the basic structure of the grant application, and you can see that number 4 is highlighted. This is the project narrative, and this is where I'm really going to spend some time today to really give you some detail and some insight into how we want you to be thinking about each of these sections. And you want to make sure you include all the components by the May 19th due date in grants.gov in order to be considered. So here's some basic tips for getting this work done. It's a good idea to start to prepare an outline according to the sections. The sections of the RFA are organized in a way to create a sort of flow. And so this is a great opportunity for you to get some of your thoughts down and think about which information belongs in which section. And you may find that we have to ask you to repeat some information, and that's natural. And so if you feel like you're repeating yourself a little bit, that's okay. But make sure that you're paying close attention to the points that are assigned to each of the review criteria. So Section A focuses on the population and the statement of need. And you want to be clear about why do you need this support in your community or communities. You want to talk about the pattern of youth suicide. You want to identify your target populations and your rationale. You want to connect to the needs identified in your plan and or your community readiness assessment. You want to do comparison data to add contrast and depth to your needs statement. And it's a great idea to include things like visuals, tables and graphs, as well as the text. And if you use any citations, make sure that you include those for your data. You'll want to explain what are you going to do. You want to describe the plans to draw from best practices, evidence-based practices, or other interventions that you plan to use with an explanation for why you want to use them. We recommend that you check out our system, NREP, which is our national database of evidence-based practices, and we'll provide a link at the end of the webinar. Also, the Best Practices Registry, which is through SPRC, and we'll provide a link at the end. And you may not have any evidence-based practices for your particular program. There are some populations that there's nothing that's considered quote-unquote evidence-based yet, but that doesn't mean it's off limits. It simply means that you have to explain and justify what you plan to do. And you want to talk about how does it address the need and provide the evidence and the support. If you're going to modify your proposed practice, if you're going to use something like QPR, but you're going to modify it in some way, then you have to explain why. And how does your proposal address the population that you're focused on? Make sure that you include a logic model and your plan to work collaboratively. And make sure, this is also the section where you want to explain how you're going to do follow-up after the ER discharge and inpatient unit. So Section C is where you talk about your implementation. This is when you explain to us how you're going to do what you're going to do. Talk about your purpose, your rationale, and how you're going to reach your goals. You want to give us a timeline and milestones and who's responsible. Talk about the unduplicated numbers served by your program. This is going to be an estimate. This is a ballpark. We just want to get a feel for what you plan to do. How are you going to impact state or tribal systems level change? If you are a previous grantee, how are you going to build on that work? How are youth and consumers going to have input into your program? How will you partner with other SAMHSA-funded projects in your community? How are you going to make sure that emergency care is absolutely in place for youth who are at immediate risk? How will you follow up on referrals? How will you get consent? Who are your partners? And how will you sustain? Section D is when you talk about the folks who are going to be doing this work. Why are these people the best to do suicide prevention in your community? You want to talk about how will these folks effectively promote system-level change? How are they able to perform the intensive community work that's required by this RFA? How will you incorporate substance abuse prevention and treatment? How are these folks really well qualified to do that? And how are they well qualified to do things like follow-up with inpatient and ER department discharges for suicide attempts? You want to give us all the staff positions, what other resources might be available in the community to help you do this work, because this isn't going to be just you guys by yourselves. You're going to want to make some partnerships, and so we'll want to know what those are going to be. And then you just want to make sure that you're ensuring your compliance with ADA for accessibility. For Section E, this is your data collection section. Talk about how you're able to collect the data that we're asking you to get. How are you going to use the data to improve your program over time? How will you conduct the local performance assessment and measure your program's impact on youth suicide deaths and attempts? And then will you be able to participate in a national evaluation as well? We have guidelines for assessing cultural competence. So we want to see things like experience, your track record, what sort of training does your staff have, linguistic considerations, if they're fluent in the language of the population you'll be serving. Is there community representation in your staff? And then if they have things like implementation and evaluation expertise. These are all aspects of cultural competence. So here are those good resources that I promised you. We have a number of things on the SAMHSA website, including resources for grant writing, how to develop a competitive SAMHSA grant application, assessing cultural competence, the National Registry of Evidence-Based Programs and Practices. And don't worry if you haven't written all these down, that's okay. Some of these are actually part of the RFA itself. You may have seen some links. And this webinar will be posted on the sprc.org website for you to replay. So if you're not able to jot down all of these links, don't worry. And here are some more links for you. This is our grantee page on the SPRC website, which gives you a map and a sense of some of the other folks that have been funded. We have state data sheets available on sprc.org. There's a library of resources on suicide prevention, as well as that best practices registry that I mentioned. Here are a couple more. There's a document called Taking Action. There's a model that's all about data-driven planning, which might help you in putting together your application. There's information about AMSR, assessing and managing suicide risk, as well as the National Center for Suicide Prevention Training online workshop. So the SPRC website is a wonderful resource. Really the best link to remember from today's presentation is sprc.org, because that has a lot of information that will help you with your application. So just a quick recap. When you're putting your proposal together, think public health and think about how to create caring environments for youth 10 to 24 where they hang out. Think strategically about your goals and the steps leading up to successful attainment. We want to see an emphasis on early identification. We want to know, are adults ready for youth to disclose suicidal intentions, and think about who would benefit from gatekeeper training. But we also really want to see how developed is your response capacity, and how will a cross-system referral network be developed or enhanced, because suicide prevention is really everyone's responsibility. This isn't going to fall only on your shoulders. When you think about your data, think about what's feasible to measure for your local evaluation so that you can see the impact of the work that you're doing. Always include local data and recent citations in your application. Make sure that the program plan, the methods, and the design and the staffing are all culturally competent. And again, you can refer to our SAMHSA website on cultural competence to think that through for your application. And sustainability is not something to think about at the end of your grant. It's really something to think about as you're writing your proposal. So think about what your funding sources are, think about what's available now, and what kind of relationships you can build on so that when your grant is finished, you've got some really solid programming in place that's going to continue. When it comes to actually writing your proposal, feel free to use the language of the RFA to talk about what it is that you're going to do. When you're asked in a section to provide information and then you're asked to do it again, then please do that. Be thorough and address the criteria completely. Make sure that you have someone else read it and just track on the sections and see if there's anything that you've missed. Sometimes other people reading it can be a very beneficial thing. Write from your heart and your mind. Talk about the communities that you're serving. Really paint a picture for us and help us understand what it is that you want to see happen in your system. Write logically by connecting one section of your proposal with each previous section. So let that flow across your application. Let one section go into the next. Make your objectives SMART, S-M-A-R-T, specific, measurable, achievable, realistic, and time frames, and then get honest feedback and revise your application. Get other folks to take a look at it and see what they think, because this is a group effort. I'm Michelle Carnes. That's my contact information. I'm also in the RFA, so if you need to follow up with me after this webinar, you're certainly free to do so. Also, Richard McKeon's information is there as well. He opened that webinar with his introduction. If you have any budgetary questions, you can reach out to Daryl Russ, who is here at SAMHSA. They do the dollars and cents portion of the grant. And then this is the website that I mentioned, the sprc.org. The recording of this webinar will be available on their website for replay. So if there are folks that missed it, who asked you about it, you can send them this way, and we'll be publicizing it as well. Or if you need to go back and rewatch some sections, it'll be available for you. It usually takes about a week or so, so check back probably about this time next week. And that's our spiel. So if you have questions, please dial *1, and the operator will put you into the queue. And we're here all available to answer your questions. We have the whole team on. So operator, whenever folks are ready, we'll begin to take questions.
The first question on the phone line is Kathy Boggs. Your line is open.
Thank you. I have a question about the eligible applicants. You mentioned states and previous grantees. What about nonprofits who can be designated by the state?
Yeah, the key thing here is that a nonprofit or an entity within a state can't apply on their own. The state is free to designate as the grantee either one of the department within the state, such as mental health or the Department of Health, as well as designating a nonprofit to coordinate the grant program with that. A number of states have done that, but there needs to be documentation in the application that you are the official designee of whatever state you are from. And the same holds true for a tribe. The tribe also has that option.
Thank you.
The next question comes from Pat Smith. Your line is open.
A couple of questions, actually. The first one is that initially in the RFA it says that you can choose to be specific community or communities to work with. It also says that you can also choose to have a statewide program, and that a few pages later it says that you must work intensively with one community. So I assume if you choose to say statewide, you really have two components. One is statewide and one is local. That's one question.
Yeah, I mean, I think that we want to make it flexible because we know states have different, each state is a little bit different, and so you may want to focus in on some communities with your grant. Certainly grantees have done that in the past, but we just expect to see active engagement with the communities, whichever you select to do, whether that's across the whole state or whether it's focused in on a number of communities within that state.
Yeah, and in essence, as we said, this RFA is more ambitious than previous ones. So in essence, we're encouraging both breadth and depth, and want you to have the ability to be able to work intensively in a community, but also we are hoping to promote as much as possible broad systemic change, for example, within statewide systems. So that's why there is language about both of them that is in the RFA. One thing I just might say in terms of the language of the RFA, sometimes we'll be asked questions, which is, well, what did you mean when you said, X? One of the important things to remember as you're preparing your application is it doesn't so much matter what we were thinking, it matters what we actually wrote. Because these will be reviewed by independent reviewers, and they'll do the same thing that you are. They will look at the RFA, and then they will look at your applications, and they'll score them against the RFA. We will not be able to impact them or brief them or say, well, this is what we really meant when we wrote, X. So it's really, you should take a look at the wording and make the most reasonable interpretation that you can around that, because reviewers will have no additional guidance beyond what you have in front of you to interpret that. So that may feel a little bit more ambiguous, but it also gives you more flexibility in terms of that. And we want you to be able to do what you think makes the most sense for your communities, for your state, and for your tribes.
My second question is that members of our planning group had the question, for the community that we select to work with intensively, can the initial activity, say the first 4 to 6 months, be a planning period with that community?
Well, I think that the major issue there is that you recall that Michelle mentioned that there's an 85% services requirement. That comes directly from the Garrett Lee Smith Memorial Act. Now, again, those are not direct treatment services. The law says that, but the law also makes clear that it's talking about a broad array of prevention services and prevention interventions. So I think that the issue would be that it would be hard to meet that 85% requirement by doing 6 months, okay, of planning. The RFA also does state that service delivery needs to begin by the 4th month. Now, that doesn't mean that every single component needs to start then, but the general idea would be is that obviously every state or tribe is going to have some startup issues, but that the grant really needs to start implementing activities by the 4th month. And you can certainly do planning over a longer period of time for a component of it, but you can't do straight planning for 6 months in the grant. So some grants, for example, we'll be able to spend 6 months or a whole year focusing on planning. But that's not the case because of the congressional language for the Garrett Lee Smith grants. So hopefully that makes it clearer.
Yeah, we would be implementing some activities, but looking at putting things in place in the community. I understand what you're saying. Around the 85% funding, To me, that says that you have 15% of the funding available for administrative costs within the state agency, for example. But you also say that there's 10 to 15% should be used for evaluation, data collection, performance measurement. Is that is that separate from the 15% administrative costs, or is that included in that?
I think you need to use your best judgment on that. And the 85% is the congressional language. In SAMHSA's services grant, that the other number that you refer to comes from basically the way SAMHSA's services grants are set up. We know the congressional intent was that, they wanted the dollars to support suicide prevention activities and not to kind of stop at the level of a state system for administrative reasons. I think that some parts of evaluation, some parts of surveillance are intimately linked to programmatic activities. And so I think that you can, when you look at that, I think you can keep that in mind. Some evaluation activities are inherently programmatic, and in fact, we really encourage grantees to be using data, to be using surveillance data, to know about deaths by suicide in their community and suicide attempts and various systems, to be tracking on that information and be using it to guide intervention. So that, I think that's inherently programmatic. So I would give it your, look at the language, give it your best shot.
Okay, yeah, it was a little clearer in the when we had funding previously, so I didn't know how to interpret that this time.
The next question comes from Anya Schaefer. Your line is open.
Hello. I just have a quick clarifying question about the length of the narrative portion. In the RFA, it mentions that it should not exceed 30 pages, but I believe I saw earlier in the webinar that the length is 25 pages.
Well, it is possible that they have given us 5 extra pages as a possibility.
Okay, so we're double checking on that now.
Okay, great.
But maybe we can take another, while we're double checking that on that language, we can take another question, or if you have another question.
I do not. That was all I had. Thank you.
I see it here. It's on page 25. So don't use more than a total of 30 pages. Okay. So we have you have a little more wiggle room than what I said in the slides. It used to be 25, but I guess it's 30 now. So you do have a little more time, or a little more space.
Okay, so it is 30.
It is, yeah.
All right, thank you.
Thank you for catching that.
The next question comes from Janet Killams-Lally. Your line is open.
Hi, I just need some clarification on Section F, the electronic health record. So just defining clinical services. So is providing extended follow-up phone calls considered a clinical service and therefore requires an electronic health record technology?
Well, it does. Here's my understanding of it. It's not requiring it. However, there are 5 points that are being given for it. So it's your advantage to be able to be working with an electronic health record. I do think that providing follow-up services can be a vital part and is very important to be integrated into electronic health record. But it's not required. But in order to qualify for the 5 points that are specified there, an electronic health record needs to be part of it. but again, not any electronic health record. So potential applicants basically are not getting 5 points for having an electronic health record or working closely with an organization that has an electronic health record. What we're trying to do here is to push forward and incentivize the incorporation of suicide prevention into the electronic health records. So for behavioral health and healthcare components of it, if it's going to be using one that incorporates this, then it can qualify for those 5 points. So it's not a requirement of the grant, but there's an advantage if you're doing it.
Okay, thank you.
The next question comes from Harvey Doppelt. Your line is open.
Are we able to name the organizations that will be providing services?
Are you able to? Yes.
As opposed to going through where you have to do an RFP later for the agencies. Can you put the name of the agency that will be partnering with the state in this case?
Well, here's what I would think the issue is. On one level, the more specificity, the better. But, that reviewers know what you've done and if you've, already have planning and agreements and so forth. The only dilemma typically in responding to this kind of RFA is that since no one knows whether they'll get the grant, they don't want to be signing contracts before they know that if they have the money. So really, either is an option. In the past, and for a number of different for a number of different purposes, states and tribes have used subcontracting mechanisms and have specified in the RFA that they were going to do that, but have given as much information as possible about what the intent was, what the purpose was, and so forth. Now, we do strongly encourage in the grant identifying the behavioral health provider that will be part of this or that has agreed to be part of this, and that can only strengthen your application the more you are able to to document that. So hopefully that answers, but it doesn't preclude the use of a subcontracting mechanism if a state or tribe wants to put something out to bid, for any component of the grant.
So that would mean we could also name who would do the evaluation of the grant was awarded?
Yes, absolutely.
Okay, thank you.
Next question comes from Brandy Judson. Your line is open.
Thank you. We're an urban Indian center, and so I just want to first make sure that we are eligible because we've only talked about states and tribes so far, so that's my first question.
Are you applying on behalf of a tribe? Are you an urban tribal organization on behalf of a tribe?
No, we are an urban Indian center. We're a 501c3 and we're a current GLS grantee. So I know we were eligible in the past because we were awarded in 2011.
Yeah, the urban Indian organizations are eligible for GLS grants, and you're right. Historically, they have been, and there's been no change to that eligibility, or really any of the eligibility criteria for the state tribal grants. None of that eligibility has changed. So it's still states or tribes or urban Indian organizations, nonprofits, et cetera, applying on behalf of a state or a tribe. So none of that eligibility has changed in this RFA. And you're right. Several urban Indian organizations have received funding during since 2005 when the grant program went into effect. This doesn't change any of that eligibility.
Okay, thank you. So then my next question is, as far as the state or tribal plan or readiness assessment around suicide prevention, we don't have a state or tribal plan as an urban Indian center. Are we able to use our state's plan instead of a state or tribal plan? Or should we just, we have a suicide prevention plan because we're an existing grantee, so we could submit the plan that we have in place for our agency, or we could submit our state's plan. I'm not sure what to do.
Yeah, well, basically you need to make your best judgment about that. So that's one of the sections in which, well, there are two different places, correct me if I'm wrong, Michelle, because there is one section where we are providing 5 points, and what we're really looking to prioritize and encourage is states and tribes having their own state or tribal suicide plan influenced by the new national strategy. So the language is provide evidence or documentation that the 2012 National Strategy for Suicide Prevention has been used to update your state or tribal suicide prevention plan. So anything that you think can speak to that, you can submit. So that it will be up to the reviewers whether they think, given that language, what you've submitted is worthy of being allocated points. Okay, so that's the key thing. Now, also in addition to that, we ask everyone, regardless, that they submit a state or tribal suicide prevention plan. So again, I think you need to make a decision on what is the most relevant for you, because we've not specified anything beyond that. Michelle?
I think that covers it, yeah.
Okay, thank you. So I do have a couple more questions. I apologize. As far as letters of support go, historically we go out and get letters of support from several different community-based organizations and agencies and tribal organizations and the whole gamut. In this application, attachment 1, it looks like the only thing that you guys are looking for are letters of commitment from the behavioral health service providers. So is that correct? That's the only thing that you want?
Well, I think that's the only thing that's required, if I understand your question correctly. You're free to submit letters of support. Letters of support in general are not typically scorable, per se. On the other hand, there are also things that you can incorporate into your description of your approach, because it provides backup to what you're saying that you're doing. If you're saying that you're going to be working with particular groups, then you have a letter of support from those groups saying, yes, we're working with you. Obviously, that folds together. But those letters of support are not required. What is required, I think, is really in the area regarding the behavioral health services. In other words, we'd be very worried if somebody came and said, okay, we have no connections to any mental health services anywhere and have made no arrangements, for that. That would be worrisome for any kind of suicide prevention activities if there was no mental health backup, no matter how much emphasis you were going to give on the healthcare sector versus the other sectors versus community gatekeeper training and so forth. So I believe that is a requirement, and the other letters of support are you can submit. They're optional. They're not a requirement. So if I'm understanding you correctly, that would be what I would indicate. And I think that's page 25. Yeah. So basically, you think in terms of gatekeeper training, you're doing gatekeeper training and wanting to have youth referred to care. There has to be care somewhere, and you have to show us how that is going to happen at minimum.
Okay, thank you. And then as far as the 5% to colleges and universities, does that apply to tribal applicants, or is that only for state grantees?
No, that applies to everyone. That was part of the law that was written in. The language gives you a number of different options, for how that could be utilized. For tribes, it certainly could involve tribal colleges. It can be used for states for trying to work with colleges across the state. We've tried to make the language as broad as possible to give applicants some flexibility around that. but the 5% is a requirement of the law and does apply to states, to tribes, to all applicants, including urban Indian organizations. Because of that, they would need to figure out something for that 5%. Could be evaluation as well that it could be used for.
Okay, and then my last question is back to the EHR. There's a specific wording that says the EHR must include suicide prevention. Our current EHR includes like the PHQ-9, so whether or not the person showed suicidal ideations, suicide attempts. Is that sufficient, or is there something more that you're looking around suicide prevention in the EHR?
Well, when you look at the section, which I believe is page 35, it talks about screening and assessment, and PHQ-9 is certainly, would be a screening instrument that is appropriate. But the language that we use says SAMHSA strongly recommends integrating into the EHR system suicide screening and risk assessment, ability to monitor patient progress and transition through analytics, ability to identify at-risk patients for all providers engaged in treatment with the patient, and the ability to create and share safety plans between the provider and the patient. So the more of that you have, the better you would score. Now, some pieces of that may, for example, the ability to monitor patient, progress could be built in. It may not be labeled suicide prevention, but it should be able to be used for suicide prevention. So I think what you want to do is, to the extent to which you can, show us how the electronic health record is or can be or is planned to be used as a robust tool for suicide prevention. And that's what we're trying to incentivize, not simply having an electronic health record that is silent about suicide and suicide risk.
Thank you.
The next question comes from Denise Brand. Your line is open.
Thank you. Can a tribe conduct a community readiness assessment specific to suicide prevention now if it's completed by the application date?
Sure.
Okay. All right, that's good news. And then also, could a tribe designate a nonprofit to apply on their behalf?
Yeah, that'd be fine too.
Okay.
Yeah, and that language is in the is right in the RFA that talks about. Again, you would want to make sure that there was something in writing that shows that the tribe has designated the nonprofit to apply on their behalf.
Sure. Okay. Thank you.
And our last question comes from Jared Hyman. Your line is open.
Thanks. Can you just provide some clarification? I know Michelle, you mentioned kind of an and/or when talking about the state suicide prevention plan versus the community readiness model. If a state has not, or a tribe has not conducted a community readiness assessment, is your recommendation for those 5 points is that we try to do that between now and the due date?
What that is that provides the opportunity for tribes that don't have a tribal suicide prevention plan to be able to show us some understanding of where the community is at when it comes to suicide prevention. So we just wanted to provide an opportunity for there to be a diverse response with the awareness that one may be more suitable to one community versus another. So if you have the opportunity and you want to do a community readiness assessment between now and the application due date, which is, I think, not unreasonable, I think that would be something that would be possible to have it scored and prepare those materials for the application. Then that would be, and you could submit that for that 5-point section, and you'd have the potential to get those 5 points for that part.
So, pardon my daftness. so we have a state suicide prevention plan that was done prior to 2012, but we can justify that we've been are incorporating the national strategy. So should we, what I'm not clear on is that will we just get 0 points if we don't do that readiness assessment in that section?
Yes, that's correct. So those three sections on the electronic health record, on state and tribal suicide prevention plans, and on the community readiness assessment are all part of the total of 100 points. Right? So it's to your advantage, and it's to any applicant's advantage to do what they can to try to qualify for getting some of those points. So you gave as an example that there are ways in which you've tried to incorporate the national strategy, and so you should try to document that for that part of that 5 points. But you're also eligible to do what you can to try to qualify for those additional 5 points for community readiness assessment. Now, part of the issue is really that SAMHSA has provided a lot of technical assistance over time to states to help develop suicide prevention plans. SAMHSA has provided a lot of technical assistance to tribes to develop community readiness assessment efforts. That's why we're both in there. If we had just said that state suicide prevention plans, we might have disadvantaged tribes who are eligible applicants. Similarly, if we had just said community readiness assessments, we would have potentially have disadvantaged states who are also, of course, eligible applicants. So that was part of the thinking behind it, was to incorporate both. And we also felt that they, in fact, complemented each other. And we think it's a good thing for states to do community readiness assessments, and we think it's a good thing for tribes to do suicide prevention plans. So that's the thinking. And so you want to do what you can for all three of those sections to try to see what you can get to get some points for it, depending on where you are.
Excellent. Thanks for the clarification.
There are no more additional questions on the phone line.
Okay. I see that there's a question about the grantee meeting, and it says that the RFA says the grantee meeting will be every other year, and will that begin in year 1 or year 2?
Well, federal meetings have become a lot more complex, as some of you may know. So basically, there will not be an annual grantee meeting in years to come, the way there has been up to this point in time. So it is being designed as being every other year. We are looking at what we potentially meeting, for example, with new grantees to help assist them as part of this, as well as providing additional remote technical assistance, et cetera. So some of those plans are still being worked on, but as far as your budget is concerned, you should just follow the guidance in the RFA. But we don't have anything definitive for you as a potential new grantee about how that would be handled there. But budget for every other year. So did we say 1, 3, and 5, or how did 2 and?
So it just says every other year.
Okay. All right. So we didn't, so we were ambiguous about that, probably because we're not entirely clear ourselves about what we will or will not be able to do. We know but we will have grantee meetings at least every other year moving forward. So you've got to deal with that in your budget. The budgets themselves you have to submit. They're not scorable, but it means that if you budget it one way and it ends up happening a different way, you'll just need to make appropriate changes, which you're allowed to do under the terms of the of the grant, but we don't have definitive planning for next year for new applicants. For existing grantees, we know that there will not be a grantee meeting next year, but we are looking to see whether we'd be able to do something for new grantees.
We did have one more person queue up in the questions, and Keith Huddle, your line is open.
Okay, thank you. Hi, Michelle and Richard. Not to pile on to what Jared was saying, but we've done extensive needs assessments in our community. In fact, you may recall we developed our own workbook, but we noticed that the model that you put in the grant is different. And so is that a mandatory model that we need to use, or can we supply the work we've already done?
Well, the community readiness model is this is the folks that authored that model. But what you're saying is that you have work that sort of produces a similar result that uses a different model.
We've conducted the assessment not only at the state level, but in all of our communities.
Well, my suggestion to you would be that, if you've done that work, you should certainly submit it. It will, the question will be, how will the independent reviewers score it? If you submit nothing, then it would be clear that you would not get any points. As I read it, and again, this is just me, and it depends on how the reviewers would read it. They could potentially go in either direction, because it would, you might get some points, but not all. Because it does say submit a community readiness scoring sheet, a community readiness assessment graph, and stages. If the reviewers thought that what you were submitting was equivalent to what this was asking for, they may give you points and they may give you full points for it. So, but what I would say in essence is that there's no downside to your doing that. That's certainly better than not submitting anything for this section.
Okay, that's helpful. Thank you.
We do have one more additional question on the phone line. A question comes from Fred Preservi. Your line is open.
Hi, good afternoon. I guess I'm still having a little confusion about some of the budget requirements. On page 57, it says, under the heading of funding restrictions, SAMHSA will not accept a research indirect cost rate. I understand that totally. The grantee must use the other sponsored program rate or the lowest rate available, which now I'm having trouble understanding in the context of the 85% for direct services, at least 10% for evaluation, and the no more than 15% can be used for EHR. So those three add up to 110 now, plus it sounds like if you have and maybe I'm misinterpreting this, but if you have a federally negotiated indirect rate for administration, not the indirect research rate, but a regular one that you use for grant administration, it somehow has to fit into this mix of 85, 15, 85, 10, and maybe 15. And I have to confess, I'm just really confused, and maybe the answer is use your best guess, but I'm just wondering if there's any more clarification that can be provided.
Yeah, I mean, the issue is that the way SAMHSA approaches services grants is where the other requirements come from, but superimposed on that is the requirements of the Garrett Lee Smith Memorial Act, which are 85% in terms of services and 5% for the colleges. So it is confusing. And you ultimately do need to use your best judgment on it. It is the case that, you reference the line where SAMHSA will not accept a research indirect cost rate. And at least my understanding of that is that research rates, so for grants at NIMH, because that typically are allow for a more generous indirect cost. And so having negotiated a separate indirect rate is usually what's encouraged, lower than the research indirect cost rate. And if you have negotiated that, then you can use that. But we don't have a master guide that says for X activity, this is included as part of data but not part of evaluation, but it is a service, but it's not. So we can't provide that level of specificity, for you. The good thing about it is that most of that is not directly scorable. So if you send in a great application and you get funded, we can work with you about anything that may be problematic. There are just a couple of those areas that are directly scorable because I think that there's an evaluation criteria that asks about how you're going to be using the 5%, for example, but for colleges. So give it your best shot, and if you are funded, we'll be reviewing that. And if there are any concerns we have about any of this meeting any of these subcategories that are admittedly quite complicated, we will work with you on that at that time. But for now, I would just say, do your best possible application.
Thank you.
At this time, there are no additional questions on the phone line.
Okay. We had another question come in over the webinar platform. If a state and tribal grant are submitted from the same state, are they competing for funding or are they considered separately? The answer to both of those is yes. They are competing for funding in that there are 24 potential grants that could be made, so they will be competing for one of those 24 slots, but they are considered separately. So if hypothetically the state of Montana is putting in an application and a tribe from Montana is putting in an application, both of them can potentially be funded. One does not preclude the other, but they are both competing for those same 24 slots. So I hope that helps clarify that question. Okay, do we have any other questions in the queue? I'll take that as a no. I want to thank everybody for joining us on the webinar today. Happy writing, and please do reach out to us if you come up with any additional questions. We're happy to help. This webinar will be posted on the sprc.org website for anyone that missed it, or if you want to re-watch it, you're able to do that. It should be posted around this time next week. So thank you for joining us. We look forward to seeing your applications, and have a good day.
Thank you. This now concludes today's conference. All lines may disconnect at this time.